the Medicare program, because given the age of those people who are on Medicare, a lot of them use the services of cardiologists.
Sure.
So what needs to be done to that program to make it service the doctors and the patients better?
Well, Medicare has some bureaucratic features that frustrate everybody, patients, doctors, probably the people in the Centers for Medicare and Medicaid
The
Services.
threats of payment cuts?
Sure. The unsustainable growth rate formula that's used to pay physicians is obviously broken. To fix it is going to cost $300 billion over the next 5 to 10 years, which is like an amount of money equivalent to a year of the Iraq and Afghanistani military efforts, for example. It's an enormous amount of money, not likely to be funded. To some extent, we probably need to go fund the S-CHIP program reauthorization in March as a first priority. But we believe that you could fix quality of care issues. You could create a business sense that would cause physicians to feel okay about adopting electronic medical records and clinical decision support systems to take on the quality challenges I mentioned earlier by simply adding a 5 or 6% payment bonus for doctors in Medicare that would facilitate that.
A bonus for using the IT?
For electronic reporting to an accredited registry or system
Okay.
that would capture the data in exchange for making that the results of that transparent. We could, while we can't measure outcomes at the level of the individual doctor and do that with valid data because it's kind of a technical thing, but most doctors don't have enough patients in any one category of diagnosis to really validate outcomes at that individual doctor level. You can validate outcomes across a hospital medical staff or a medical group, but when you get down to one doctor, the data stops being valid because the patients may be so different from one practice to the next, for example. But you can measure adherence to guidelines, performance measures, the extent to which doctors practice evidence-based care. Beth McGlynn at RAND reported to us all, dishearteningly, I guess, a few years back, that only about half the time, when we go even to the very best clinics in America, do we get evidence-based care. So there's a lot to be gained there. We've got practices that the colleges working with who are out in front, who are actually using electronic medical records plus clinical decision support that reminds them if they are not abiding by the guidelines and performance measures we've taken so much effort and time to develop, and reminds them about that so that the patients in those practices, 100% of the time, get the evidence-based care. The doctor doesn't have to follow every step of the guideline, but she or he simply needs to record why they've departed, which is a way of creating a learning system so that we can see when and how we need to update the guidelines to meet the needs of patients across the community. Now, that kind of quality system would have a major impact on reducing disparities in care, on reducing ineffective care, inappropriate care. We could do a lot by just measuring our way to quality success, and that's something that the profession can do,
Right.
the professions can do, and it's really our accountability.
And you've returned to this several times in our
Sure.
interview, so I have to ask if it's a point of frustration for you that it's not farther ahead than you think it should be.
Well, it's a point of determination for me and for the college. The ACC has registries that measure quality up in 2,400 hospitals and medical centers across the country today. So we are measuring quality in inpatient care, and we're giving the hospitals feedback on how they each do with respect to all the others in the system. And that's powerful. We've been able to demonstrate, for example, in the nation over the last year in something we call the Door to Balloon campaign. It's really the door to the emergency room to balloon being an angioplasty or a stent or a cabbage surgery. When somebody's having a documented heart attack, and there's just no doubt about it, we call that in medicine an ST elevation, myocardial infarction, or a STEMI. When you're diagnosed with this certain heart attack, we need to get the blockage in your coronary artery opened up within 90 minutes, or you will have damage to the heart muscle beyond the blockage that will be a scar and won't heal. That damage will put your heart at risk for heart failure and other problems throughout your life, probably causing you to have serious morbidity later. So getting that done in 90 minutes is important. And if you ask, the best centers in America, if they achieve the goal, that's what the science says, they will all say to you, yes. But when we measured using our registries how we're actually doing, we found that 2/3 to 70% of America's hospitals were not reperfusing, not getting the blocked artery opened up in 90 minutes. As soon as we gave all the hospitals the data, within a year, almost all of those hospitals had in fact achieved reperfusion, clearing the blockage in less than 90 minutes. So here's something, this is a powerful thing. No money was exchanged, nobody got any payment rewards, but what happened by just simply giving people the data about how they're doing was enough to radically transform the care to the benefit of patients.
Okay, fair enough. But I do want to end this interview going back to the idea of national health care reform. And on that point, if the college could ask the next president to do one thing in the first year, what would it be?
Well, we would say expand access to those who do not have coverage and make sure they're included in the system. Take them out of the emergency room as their medical home and provide a way to take care of them.
Okay.
But I'm going to just put a little bit of an asterisk on that, because I don't think we have the money. I think after we reauthorize the S-CHIP program next year and we fiddle around with some of the things we have to do that are on the table, I don't think the dollars and cents will be there this year or next year. So I would suggest we spend a little bit of money on advancing quality of care and creating a business case for doctors and nurses and practices to do some of the things I've talked about, which will start saving dollars, improving care, and reforming the system in ways that incentivize quality, patient safety, the end of disparities, and so forth. These are all very important things that we could do while we're waiting to come up with the dollars for the big fix.
That's a really interesting approach, because so many of the people I've talked to in this interview series, the phrase I keep using is they want to go big and bold, which by definition I guess is expensive. And yet you're saying something very different, based, you say, in realism that the money isn't there or won't be there.
Well, maybe it will be there in 5 years. Maybe we get these conflicts resolved and the economy improves. We'll be ready, and that gives us some time to think about how to solve the big problems in the most effective way. But in the short term, there are things we can be doing that really will positively impact the system and prepare us for a less expensive big fix.
Okay, very interesting. Thank you,
You're
Dr.
welcome.
Jack Lewin.
Thank you.
The Kaiser Family Foundation presents health08.org, election news, analysis, and events.